And now we turn to our panel. Dr. Fatima Cody Stanford is an obesity medicine physician at Massachusetts General Hospital and Harvard Medical School. Dr. Kavita Patel is a practicing primary care physician and non-resident fellow at the Brookings Institution, and she's working right now, I should say. And Joe Nadglowski is president and CEO of the Obesity Action Coalition, a not-for-profit dedicated to giving a voice to individuals affected by the disease of obesity. Welcome to you all. Dr. Stanford, it's great to see you again. You and I have spoken before about how so many of these chronic conditions are a function of systemic realities, and we have a way of demonizing the patient, of demonizing the victim of these systems. And I'd just be interested with our audience listening to us today as we think about how do we move this? How do we think about TROA and what it's doing and sort of allow something that I think should have probably been in place before, but how do we turn around the dynamics so that there's embrace of obesity as a disease that's a function of a system that deserves both respect and treatment, if you will? You're muted, Fatima.
Yes, it's Fatima also. Thanks so much, Steve. It's a delight to be back, first of all. So I think this is great that you're doing this. And I think that you're raising some really key points on how we begin to view obesity differently. I think Congressman Ruiz did a really good job of really setting us up for how we evaluate obesity different compared to other disease processes. And when we have this different evaluation, a lot of this is based on the fact that we just have not been very educated. So a lot of what I'm doing is making sure that we educate the general public along with our physician and physician colleagues about this disease and the importance of treating it and the importance of the systemic nature of the disease that you brought up. Now, when we look at TROA, the Treat and Reduce Obesity Act, you're right. It is far too long that we've been reintroducing this into both the House and the Senate that it hasn't gotten passed. But it's only now that I think our senators and our congressmen and women are beginning to understand how we're getting behind, further and further behind when we look at the progression of obesity in our country. The CDC released their recent obesity maps within the last 3 or 4 weeks through 2020, so taking us through the beginning portion of our COVID-19 pandemic. And what we've seen is a consistent rise in obesity amongst all racial and ethnic groups, but particularly in persons of color. If we look at the non-Hispanic Black population, people that look like me, we've seen rises in obesity that are disproportionate to what we saw even prior to the pandemic. We have to do better, and that's why I'm so happy you have us here discussing this very important issue of obesity and how we have failed to cover the most vulnerable persons within our population.
Well, I'm just so happy you're here, and I am grateful for it. Dr. Patel, I'm always grateful for your time. You're one of the hardest working physicians I know, seeing real people in the middle of this, so thank you for squeezing us in. But you know health policy, you know real people. I'm trying to sort of understand the gap between the real person, the system we're in, and what can the public policy scaffolding around this, what should we expect of it that it's not providing right now? And I guess part of the question I have, is to put one little tidbit in it. I've talked to a lot of folks about obesity and wanting to be treated, in terms of the same kind of access that other chronic conditions have, or getting at the same level and being combined with diabetes. But I have to say, even diabetes is of diminishing significance if you look at it in terms of the research dollars that are going into it. Right. So I'm just wondering, how do we change that vector? Because 40% of Americans are suffering with obesity, and we're blaming them and not addressing the system.
Yeah, no, Steve, thank you. And thanks for having me. It's been great I learn a lot from some of the folks you have on this panel, so it's great to be on with them. So a couple of things. I'll just say, for me, some of the biggest milestones, just recently, we were able to lower the age for which we can screen for diabetes. And a lot of that has correlation to what we've been talking about, that we have 40% of the population with, and by the way, obesity is not one thing. It's like cancer. There's just a lot of varieties and certain levels of obesity. And I've kind of often reminded myself, or if there's medical students or fellows around, there are people with obesity, just like we say, persons with diabetes. So it's a way to get to what you're describing, Steve, of kind of really putting it for what it is. It's a chronic disease, and there's so much between shaming and blaming. But I'll say, to your point about kind of scaffolding and what we need to do in the public policy arena, we've long had kind of a problem with what I would say fee-for-service medicine. I get paid, I'm just going to be blunt, I get paid a lot more, even in my like primary care setting, not for obesity counseling or diet or nutrition counseling. I get paid a lot more if I can do an EKG, if I can do, inject a joint. That's not what motivates doctors, but at the end of the day, when you're trying to pack something into 15 minutes, you tend to do the things that you think you can get done in those 15 minutes. And then you constantly put off what you know will take time, or you try to put that burden on somebody else. I'll refer you to endocrinology. I'll check these labs and then I'll figure it out. What I'm seeing, and I'm trying to do this myself, is we need to have better training in primary care to deal with kind of a lot of the new medications, a lot of some of the interventions that have been proven to be effective. But then from a policy standpoint, Steve, we don't pay for these medications. We don't actually authorize or encourage or even incentivize the use of some of what we know works with patients. And then just, I think Fatima kind of put a very, I would say, a blunt perspective on people we leave out. It's very, my population behind these curtains is mostly Latino. And it's a very different thing to go up to a Latina woman and tell her, like, you need to change your diet and you need to do this. For me to do that and kind of do it when my arm is out the door, it's not, behavior change is hard. And I would probably benefit from a policy standpoint with kind of understanding kind of behavioral intervention techniques way more than paying attention to, some of the like more physical exam techniques that now we've actually proven, Steve, that you don't need. You don't need an annual physical exam, but you probably need a semi-annual kind of health checkup, especially if you've been battling with obesity and been dealing with it. So policy-wise, you had the representative on. He's incredible. I think we should talk about ways to incentivize the behaviors amongst health professionals, but also figure out a way in employer-based programs. There's lots of these wellness programs I see. They just skim the surface because they're not really getting into the nitty-gritty and the comorbidities. I've yet to meet a man or a woman that has obesity who feels good about it or doesn't have some other issues they're struggling with. And so I come to this kind of asking, I think, for help from some of the people that watch your events to think through, how can we prioritize with an infrastructure package going through? We were talking about new Medicare benefits, hearing, vision, dental. That's incredible. How can we talk about, kind of spreading that across the population with expectations for benefits around obesity? And also, I'll just say kind of behavioral interventions and teaching that to health professionals, community health workers, and people who are accessible.
Look, I just want to say thank you for that, Kavita. And we're friends, and I just appreciate the framing. I just want to tell our audience that it's close to $500 billion, $500 billion, the healthcare costs related to obesity. So it is not trivial. It is not small. I think it's beginning to address it. And I'm going to go to Joseph Nadglowski for a minute. Joseph, I was just talking to a very, very informed person on the science and healthcare of obesity. And she said something to me that really just stuck me. And I've been trying to sort of get myself into this deeply and read. But she said something. She said, Steve, a lot of people just think this is, an optional situation, that it's just, can come and go. They can be treated. You could just cut your calories and, all of a sudden you're better. She said, imagine lung cancer. So you're treating for cancer. You're going to have residuality. You're going to have a dimension of this that remains in place. And so when in a disease, the ongoing dimensions of fighting a disease, are not something you can just diet off. That it's such trivial, vapid thinking in a way there, and how you kind of begin approaching it, which is why beginning to look at a combined, therapies of medicines, of looking at, different dimensions to begin to try and tackle this, and to do it at scale, so that you actually, as the congressman just said, that you reap these saved costs, not only and saved lives, by the way. And so I'm just interested, Joseph, help us understand framing that we can take from this moment here and begin trying to explain to others why it's so important we begin making a different sort of dent in this challenge than we have so far.
Thanks, Steve, and thanks for the opportunity to be here today. This is something that's pretty personal to me because I'm a person living with obesity, right? I know this firsthand. I know the attitudes that society has heaped on me, and frankly, I've absorbed and internalized where I blame myself because of my body weight. And it was actually under the care of a caring physician who actually, when I finally worked up the courage to talk about my body weight, that she guided me towards better health and seeking the kind of care I need, and actually helped relieve some of society's pressures. So I think the key message we need to deliver to the public is, if you are struggling with obesity, or if your body weight is impacting your health, it is okay to ask for help. And then we need to make sure the system is in place to make sure that people can get it. So if you wake up this morning and today is the day, I want to do something about my obesity, we need to take away every barrier that's in front of people. And some of those barriers are, some of the examples that Mr. Ruiz is talking about, or sorry, Dr. Ruiz is talking about in terms of putting forward the Treat and Reduce Obesity Act, but some of the other system areas as well. I mean, this is not just a Medicare problem. This is private insurance problem. This is an employer problem. We even heard Kavita talk about, some of the wellness programs. Again, some groups are just tackling this issue on the surface instead of actually saying, you know what, we need a comprehensive approach to be able to address obesity, and recognize that we're all not the same. So what works for me may not work for the next person, may not work for my dad, may not work for my son, may not work for my mom. We're all different. And so this really takes personalized medicine. And we have to be careful that we don't oversimplify this problem, because I think for too long we have oversimplified obesity as just a failure of personal responsibility. It is something much more complex than that. It is actually truly a disease.
Joseph, thank you for that. To go back to Dr. Stanford, and you and I have talked about it. I think one of the most depressing, sobering things I have learned in many of the health forums I've had the privilege to moderate is, if you talk about COVID and its impact on different communities in America, you talk about maternal mortality, and you go to the Black and brown communities, it just makes me crazy that you just see the healthcare system not providing equity and outcomes. It makes me crazy. It makes me so depressed. You tweeted, very powerful tweet, I'm going to read it. You said, in my testimony today at the American Medical Association, I was told to relax when speaking about inequity in medicine, despite that the number of Black physicians has only changed 4% in 120 years. It's clear that some do not believe in equity. I have found this when we've done community forums, many of the same things, that the challenge of trust in healthcare, and as we're dealing with a topic today of obesity, where stigma has also been, those trust dynamics are so complex in this challenge, and then when you add yourself to the Black and brown community, it's even so much. And I just want to ask you, and I know this is unreasonable, what is the pathway? I mean, I know I don't believe in silver bullets in this. Maybe silver bullet's the bad metaphor here, but what is the, what are some of the fixes that we can begin credibly thinking about the unevenness? Kavita Patel just talked about, the community that she's talking about. It just, it's unrealistic to go in and, talk to some of the women that she's meeting about, hey, snap your fingers and be different. Sorry to go on so much, but it just really upsets me, and I'm just interested in your thoughts on what we can do differently.
Absolutely. So I think this is obviously an issue I'm extremely passionate about. And as a Black woman born and raised in the South, in Atlanta, living obviously now here in Boston, I think about this all day, every day. Like, how do we get to the communities that really need this work? How do we make sure we ensure that? And that tweet that you read really gets to one of the key issues. Right now, we don't have the population of healthcare providers, ranging from physicians to NPs to PAs, that look like the population that we are trying to serve. What we do know from data is that Black patients prefer to see Black physicians because there's a sense of trust that's garnered. Right before I got on the show today, I had a Black woman patient who we've been trying to get to metabolic and bariatric surgery. And she was having cold feet. She was doing all of these things. I got on the phone, contacted her, put her on video, and had a heart-to-heart that I think that I only was able to have because of the fact that she identifies with me as a Black woman. And I was able to get her back on track. I've been seeing this woman for over 2 years. And so she was kind of pulling back, but I had to go in. And that sense of trust, getting me on the phone, looking me in the face as we talk through some of her concerns is what I think is needed. When we look at the AAMC, the American Association of Medical Colleges, and look at who's most likely to serve underserved populations, underrepresented populations, from 2000, 2005, 2010, and 2015 data, consistently Black physicians are most likely to want to do that work. It's been shown in their data. Yet, like I said in that tweet, we've only seen a 4% change in the number of Black physicians in 120 years. we have to do better. We need to have a population of physicians, not only that look like me, but those that are also empathetic to the needs of the Black and Brown communities in the United States to really render the healthcare that's so desperately needed, particularly surrounding chronic diseases like obesity, where we see disproportionate impact in communities that look like mine.
Well, thank you for that. Let me just ask Dr. Patel for a moment. This may be naive, but let's be naive for a moment. Let's just pretend that TROA passes, that we live in a new era, that reimbursability, that Medicare coverage and Part D coverage of the behavioral therapies, the medicines that are needed is out there, and that's the law of the land, and we have that. And that sets a bar that maybe other insurance companies in the private sector, in the non-Medicare space, begin to mimic too, because I've just learned how uneven and wobbly that world is as well. But I guess my question is there a way in the rewiring of how we pay for things and what we cover of beginning to address more the equity question, the disparities in coverage and outcomes across racial divides in this country? Or is that a naive element
No.
from your perspective?
No, not naive. Steve, you're asking, I think, some of the hardest questions. So it's kind of probably what haunts all three of us, because we think about this a lot. I've kind of transitioned in different phases of my life between what I'll call more kind of concierge type care to where I started my training in a community health center. And I will say this, I would love to be able to see if TROA passed, and then also see that kind of matched in the Medicaid population, because so much of the equity issues come when we break down in these silos of insurance. And I would love to actually see, much like we're seeing in Medicare Advantage, where you're seeing a real flourish of kind of, direct primary care, almost, I say concierge, and some people say that's negative, but something where you really feel valued and that your voice is heard as a patient. But what we face in many of the settings where we have Black and Brown communities is incredible kind of problems for access points, time to see a new patient, time for follow-up, time to just have the most common complaint I hear, and they're saying in respect, is it's hard for me to talk to a doctor when I don't have an appointment. So if you imagine the 15 minutes twice a year is all I have with somebody, and 99.9% of your life is happening, and it's creating and shaping what we do, what we think, how am I going to have an impact on that? So I think your comment about kind of Troy and some of these incentives has to be paired with what I would say is the hardest job, which is really changing the delivery system. I have seen it since I started in my career, most notably in Medicare Advantage, by the way. I would love to see some of those principles kind of brought into Medicaid. And then I want to remind people, we still have a large uninsured population that actually has ticked up a little bit because of changes and requirements for insurance, lack of a mandate. So we need to have something that can also get decentralized outside of healthcare and be offered. I mean, COVID vaccines are a great example. I can go anywhere and get a COVID vaccine. Wouldn't it be amazing? It was something I wanted to do, but it's too logistically challenging. Wouldn't it be amazing to also go to that pharmacy and be able to have a conversation with that pharmacist who might be taking your blood pressure or might check your weight, and have that initial conversation in a more relaxed setting and kind of on your time, like Saturday at 6 p.m., because you're not working and you're not stressed about getting back to your family, for example. So those are the structural issues that can be paired with what I think in Troy and some of the bills that are moving through Congress need to happen from an incentive perspective.
Thank you. I'm gonna take an audience question and address it to Joseph. Here we have. So let's listen to a question from Sarah Mills. Sarah?
Hi, thanks for taking my question. My name's Sarah Mills, and I'm the manager of health strategies at Share Our Strengths No Kid Hungry campaign. I'm just curious about the role of food insecurity screening and intervention in obesity management and prevention, and if there's a way to integrate that into the standards of care. Thank you.
Thank you. Joseph, your thoughts?
Hi, my name's Christina.
Joseph, your thoughts?
Thanks for that question. I think, I know we've spent most of our time today talking about treatment, right? But I think we recognize, I think all of us recognize that it is going to take a combination of prevention and treatment efforts. I mean, if you think about this, I often use this example. I'm from Florida, right? So I have to wear sunscreen every day so I don't develop skin cancer. But once I develop skin cancer, I do something else. I get some additional treatment, right? And so that's ultimately what our hope is for obesity. Yes, let's work on prevention, but then also add treatment when necessary. So on this issue of food insecurity specifically, I think this is another great example, right? When we look especially at our work around children, right, where in adults, our obesity rates are over 40%, but in children, they're closer to 20%, right? There's still a large population that we need to address prevention issues for. So I just want to be very clear. I'm 100% supportive of that. I think it's an important part of the work we do, and that as we move forward with this, we shouldn't fight about whether we need to prevent obesity or we should treat obesity. We need to do both, right? The answer is we need to do both. And frankly, as a country, we should be able to do both.
Joseph, quick follow-up. You and I were just on a call and talking with a very, very interesting person from Harvard and saying, we don't frame the science right. We don't frame the science right of what's going on. And because we don't frame the science right, the media doesn't frame it right, the political sector doesn't frame it right. I'm just wondering if we need a campaign to kind of come in and help people understand that it's not just a food issue, that there's something deeper, more biologically based that's a key determinant, and it affects such a large swath of the population that those old frames clearly are inadequate for even framing or determining how to do that. I mean, tell me where I'm wrong.
I don't disagree with you at all. And in our rush to make obesity bad, we have oversimplified the problem, and we've delivered messages to the public that frankly are wrong, right? And trying to be simple, we've oversimplified this problem. We've created this, in effect, cesspool of bias and stigma that we have right now. Right. A pet peeve message of mine is we tell people that if you reduce your calorie intake 3,500 calories a week, you'll lose a pound, right? Well, I've been working on keeping my calories reduced by 500 calories for the last 25 years, right? That means I should weigh 0 right now, right? I mean, I theoretically should have lost my entire body weight, but that's not possible, right? That's not what happens. So let's be careful with this messaging. And I agree with you. Maybe it is a time for us to, and maybe the public's ready for this. Now, the challenge, of course, is that every single one of us has either gained or lost weight at some point during our lifetime. So we all think we're experts, right? And I think as we deliver a campaign like that, we have to be very, very clear that obesity is complex, and we're all different. So what worked for you might not work for somebody else.
We have another question. Thank you, Joseph. I have another question here from Christina for Dr. Patel and Dr. Stanford. Christina?
Hi, my name's Christina Badaracco, and I'm a research scientist and registered dietitian at Avalier Health. And I would like to know, how can the policies and best practices discussed today better incorporate and indeed prioritize care by registered dietitians to support dietary behavior change and maintenance to sustain these health improvements over time?
Thank you. Kavita, your thoughts?
Yeah, I'll start. I've had great success working with hospital-based dietitians, especially around inpatient issues. And candidly, that's kind of where a bulk of quote, healthcare dietitians get based, because active issues with patients that are ongoing diabetics, recovering from infections, et cetera. What's been hard is in the community-based setting, it applies the same thing with dietitians and kind of training and policies that kind of incentivize the way we structure outpatient services or things in my office have a lot more to do with the fact that I can't sustain, even in a very busy clinic where we have several doctors, we don't have the volume to sustain a full-time dietitian. And we haven't embraced, healthcare is the only kind of sector I know that still uses fax machines. And so, we really do need to find a way to embrace, hopefully through more of this movement towards kind of global reimbursement or something where I don't have to worry, what's the code for that and what's the referral to send someone to a dietitian? Plus, I'm kind of operating blind. I'm not necessarily working kind of hand in glove with a dietitian who understands my population, but yet when I'm trying to kind of find those services, it's hard for me to match that based on the personality of my patient, what I know that their stage of readiness is or activation, kind of in habit changes. And those are hard for a dietitian to kind of receive without having any of that context either. And so, again, I keep going back to really basic structural elements. We need to embrace one of the good things out of COVID. Steve, you and I have talked about this. If there is a good thing, it's the embracing of telehealth. We're on a Zoom where we would normally be in person. We need to be able to, how great would it be if when I go to my visit, I realize I need to kind of work with a dietitian. I have a way to find quickly which type of dietitian has had some of the training or expertise for a 38-year-old Latina woman who has a BMI of this and is in a stage where she's ready, but doesn't have the skill set and might not have the knowledge, and then be able to match her in that moment on her cell phone. And wouldn't that be amazing? And that's possible, but there are financial barriers as well as just structural barriers that make that just not, it's something that we don't do. I'm still faxing.
Oh, thank you. Well, Fatima, I'm going to give you the last word in responding to her, but I'm going to, also kind of, tag on to this that, going back to what Joseph said, and as I just think about these questions and how to be real about them and not just have another event, another healthcare event, like how do you be real? A lot of it when I think about, with all due respect to all the voices in this on the, the diet side, kind of beginning looking at things, I'm just interested in how we look forward. 40% of the country has this challenge. And I'm really interested as we look forward, as opposed to litigating what we got wrong in the past. I just love to know in response, and also responding to Christina, but do you have insights into whether it's TROA, but I think it's got to be so much more beyond in terms of really beginning to kind of do something at scale that begins to impact this disease in this country in a real way?
I think we need, Steve, all hands on deck. When you talk about the scale of the problem, right? We talk about 20% of the pediatric population with obesity, 42.4%. That's 2018 data. I must want to clarify. So much likely a much higher percentage of adult patients with obesity. We have to go across all sectors. I think that we've traditionally tried to look, only to, let's say, dietetics, or only to physicians, or only to schools, and we really, with the problem of this magnitude, we need to have all hands on deck. We have to have government and the political sphere involved. We have to have faith-based institutions involved. Everyone needs to be involved in first getting the right messaging out there about obesity as a disease, the complexity of obesity as a disease, taking away the blame and shame game that's been all too common across populations with obesity, recognizing that we need a range of therapies, starting from prevention to lifestyle and behavioral, medication and surgery, depending upon the individual, and recognizing that we need chronic care for these patients. So unlike what Kavita said, as someone that works in a multidisciplinary center that only treats patients with obesity, I have always worked with hand in glove, as she stated, with dietitians that get and understand my patient population. We have now 4 full-time dietitians, 13 obesity medicine physicians, 4 bariatric surgeons, 4 psychologists. This is the type of environment that we expect for patients to thrive in. But how uncommon is that throughout the country? In some ways, it's a little bit, ivory tower-like for me to be at Mass General and have access to that level of resources for my patients. I would love for my family in Atlanta to have access to that same level of resources, have that degree of individuals that are really tailored to addressing obesity across the age spectrum, across the spectrum of different modalities of therapy. And that's where we need to go. And I think it's going to, like I said, require all hands on deck from every sector, even sectors that don't believe that they would be needed within this struggle that we've had to address obesity within our country.
Well, thank you. I'm such a fan of all of you. And, as Kavita knows, from many discussions we have, I'm a playbook guy. I sort of think about, how do we get to what, Fatima, you just described? How are the processes? How do you fund this? How do you pay for it? How do you build in the patient, build it around the patient, not forget the patient? There's so many different dimensions of this. I really am so grateful for the conversation. Dr. Fatima Cody, Stanford obesity medicine physician at Massachusetts General Hospital and Harvard Medical School. Dr. Kavita Patel, practicing primary care physician and non-resident fellow at the Brookings Institution. And Joseph Nadglowski, president and CEO of the Obesity Action Coalition. Thank you all so much for your candor and your insights.
Thanks for having us.
Thank you.